Good evening. Welcome to Ask the Expert, presented by Mary Washington Healthcare. Tonight's session is the first of a three-part series featuring cardiologists and cardiovascular providers from Mary Washington Medical Group. During this session, our experts will discuss specialized conditions and treatments like cardiac electrophysiology and cardiac devices, including Watchman. We will also cover general cardiology, including management of atrial fibrillation and treatment of hypertension, coronary artery disease, and postural orthostatic tachycardia syndrome, or POTS. This program is called Ask the Expert, so of course we will answer your questions live. Our providers want to hear from you. To submit a question for our panel, simply drop it here in the chat on Facebook. Today's panelists have a ton of experience with cardiology and electrophysiology. They are truly experts in their field. Let's meet them. First, we have Dr. Daniel Carlson. Dr. Carlson specializes in treating various cardiovascular conditions, including hypertension, coronary artery disease, and arrhythmias, such as atrial fibrillation, supraventricular tachycardia, and premature ventricular beats. Dr. Carlson provides a range of procedures, including cardiac catheterizations, transesophageal echocardiograms, cardioversions, pacemaker and ICD implantations, as well as ablations for arrhythmias. He holds board certifications in cardiac electrophysiology, cardiovascular medicine, and internal medicine. He's a native Virginian, and he comes to Mary Washington Healthcare after serving honorably for 25 years in the United States Army. Next, we have Dr. Ijaz Khan. Dr. Khan is board certified in internal medicine, cardiovascular diseases, and cardiac electrophysiology. He provides comprehensive electrophysiology services from simple pacemakers to complex procedures like lead extraction. Dr. Khan has great skill in performing complex ablations, including those for atrial fibrillation, premature ventricular contractions, supraventricular tachycardia, and Wolff-Parkinson-White syndrome. Dr. Khan has over 15 years of experience performing electrophysiology procedures. Wow, that is a mouthful. So welcome to you both, and thank you for joining us tonight. Dr. Khan, I'd like you to start the program by telling our viewers a little bit about electrophysiology and the types of cardiac issues that you treat.
Thank you for having me. It's a pleasure to be here with the audience. Electrophysiology is a part of cardiology. Those audience who are familiar with the services, it comes under medicine, and it mostly focus on arrhythmia or irregular heartbeats. And there are different types of arrhythmia, irregular heartbeats, and electrophysiology addresses it. And most of the arrhythmias are treated with the different procedures. So that's what as an electrophysiologist we perform to correct them.
Thank you. And Dr. Carlson, in our introduction here, we talked a lot about A-fib and arrhythmias. Can you tell our viewers a little bit more about those conditions and how you treat them?
Yes, of course, and thanks for having me. So atrial fibrillation is one of the most common or the most common abnormal sustained heart rhythm that one can have. It's basically a disorganized or unorganized activity of the top two chambers of the heart. It can cause symptoms or it may not cause symptoms. It's more common as you get older. So in the older demographic, we see it quite often. It can cause symptoms. It can potentially cause a stroke. It can cause heart failure. So it should be addressed and it should be treated. And we're trained and quite experienced in treating the arrhythmia. And there's a variety of different procedures and lifestyle changes and potential medications which can be used to address patient's symptoms or someone's symptoms or their risk for stroke or heart failure.
Thank you. And we have a lot of viewers who have questions about cardiac issues and maybe symptoms that they should be looking for. We received some questions in advance of tonight's session. So we'll go through a couple of those while we're waiting for our audience to send in some of the questions that they have tonight. So first thing, and maybe we'll do a little mythbusters here of our own, because we have a couple people asking if they should take an aspirin every day to keep their heart healthy, or if there are other supplements like vitamins that they can do to keep their heart healthy on a day-to-day basis and help avoid any cardiac issues. Dr. Carlson, what would you say to that?
Oh, well, thank you. So it's somewhat challenging to follow the pros and cons of a daily aspirin. I can tell you, if you've had a stent or if you have known cardiovascular disease, then it's generally accepted you should be on an aspirin a day. If you don't have heart disease, then sometimes it's debatable because there is a slight risk of bleeding when you are taking an aspirin. So if you're low risk, or a very young person, low risk, or if you're older and you're at increased risk of bleeding, and it's probably not a good idea to take an aspirin just to prevent any problems. But if it's a little bit more debatable if you're kind of in the 50 to 70 age group and you might have a couple risk factors for heart disease. So I think that's someone who I might suggest taking a daily aspirin. But I think it's fallen a little bit out of favor for prevention of cardiovascular disease. But if you have it and you have a stent or you have coronary disease, you should probably take it. Then with regards to vitamins, I think that's a little bit that can be touch and go as well. Some people believe in them, some people don't believe them. Probably a multivitamin, it's not going to hurt you. Some people ask about fish oil as well. There's some newer prescription fish oils which may be good for the treatment of high triglycerides and in an effort to prevent heart disease or progression of heart disease. I think I could support that. But in general, I wouldn't advocate for expensive supplements unless you talk to your provider about it first, and then that may be an option.
Thanks, Dr. Carlson.
So, Dr. Carlson, so since we were talking about the supplements, so you're probably aware of that some of the fish oil can increase the risk of having A-fib. So what's your thought on that? Would you go to people who already risk A-fib, or are you going to say, no, not for those people only who don't have risk factors for A-fib?
That's a good point. Yeah. So I guess I would you got me there. So in general, I'm a big less of a supplement person. So if someone was asking me about fish or fish oil, I'd advocate maybe a couple servings of fish a week. And then if they really push me on fish oils, I agree with you. There is some data to suggest that it may increase your risk of AFib, may increase your risk of bleeding. So I might be hesitant, especially if they have AFib, or that it could certainly do that, right?
Yeah. So the other with the supplements, I know so many patients ask every day. Sometimes they bring their bottles and say, whether I should take these supplements or not. And one that comes to mind, you do general cardiology, and cholesterol that we treat with statins, like different statins, that causes some leg cramps and muscle weakness. And most of the patients, I don't know where they get the information, but I think taking like a CoQ10 can help with it. So what's your experience? Have you seen any patients who say these things to you, or what's your experience with those kind of supplements?
Coenzyme Q10, I think that's some things kind of rise and fall in popularity. If you go back many years, it's with B vitamins, then it was vitamin E, then vitamin D, and coenzyme Q10, zinc. And I just heard a commercial the other day for coenzyme Q10. I don't think I've ever started CoQ10. Well, let me say that. Some people, if I'm really trying to get them on a cholesterol lowering medication, a statin, I might encourage them just to try it if I really want them on a statin. But I wouldn't say that I'm a believer in it.
I agree with you. I don't believe in it either, but some of the patients do ask. They bring the CoQ10 and say, can they take it or not? So I wanted to see what your thoughts were on that.
It's a little bit of the art of medicine. There's a science of medicine, and there's the art of medicine when you're talking with patients in clinic and trying to meet them in the middle somewhere.
Good.
And there are some questions too. We're talking about medications or supplements, but a lot of people wonder too how much their diet can impact their cardiac health. So we've had people asking, is it okay for me to have a glass of wine every day? Does it matter if it's red wine or white wine? Or what about eating eggs? When I was a kid, there was a PSA campaign for, the incredible edible egg, but then it seemed like right after that, eggs were a no-no. So what comments or wisdom would you share with your patients or for our viewers tonight about what they eat or drink for their cardiac health? And Dr. Carlson, we can start with you.
Oh, I was going to say what Dr. Khan would say about this. Regarding alcohol, we were talking a little bit about alcohol, right? I think that's kind of like an aspirin. It falls in and out of favor at times. There's traditionally been associated or discussed this J-shaped curve. So, of course, alcohol in excess can be bad. I think we all know that. And then there's a thought that maybe some alcohol in moderation may be a good thing. And I'm not so sure of that anymore. I think it's really kind of an individual decision. So if you enjoy it, or if that's part of your culture, I wouldn't necessarily recommend against it, but I would caution people that I'm not sure how beneficial it is for one's health, to be honest. But certainly excess alcohol is bad. It can lead to more atrial fibrillation. It can lead to heart failure. It may increase the risk of bleeding. So I'd be cautious, and I don't counsel people to start alcohol these days. And then the eggs, that's a good question. I think my personal professional belief is that oftentimes there's cholesterol in eggs. But I think how much cholesterol you actually eat has a weak influence on what your cholesterol levels are in your body. So I think it's often genetically determined what your cholesterol levels are, and more influenced by your your totality of your diet, your fruits, vegetables, soluble fiber. And so I don't think that one or two eggs a day is necessarily harmful. It's going to affect your cholesterol that much. I'd be interested to see what Dr. Khan has to say about these topics, whether he's an egg eater or not. Any thoughts?
Yeah, so coming to the alcohol, so I tell my patients not to drink whatsoever. I'm totally against it, especially people who have A-fib or any other arrhythmia, really. And I have so much experience with a patient who don't drink. It's very easy to control their A-fib. You just give them something and it goes away for months and years. We cannot cure it, obviously, but it helps minimize burden of A-fibs having zero alcohol. And I think I would strongly believe that a non-ischemic cardiomyopathies like the heart failure that we see in the country is all attributed to alcohol. Because I couldn't find any other resource that it will cause such a big, almost 2/3 of the in SCUD have for the non-ischemic cardiomyopathy. And the only thing I can come up with is the alcohol consumption. And I don't believe that it has the number or the amount of alcohol people consume. I think every human being is different. Some patient can drink like a gallon of alcohol, nothing happens to them, but others can just drink a small sip or a small glass and it affects their heart. Why it happens and who is at risk, I cannot tell. Only retrospectively, we can say that it's because of alcohol. So I usually tell my patients to avoid alcohol and only have it on special occasions.
That seems like very good advice, Dr. Khan.
And as far as the eggs go, so, eggs, Ben, as you mentioned, and falls in favor, then comes back, and some people like it, some don't. But most of the data suggests that eating eggs is not going to influence your cholesterol level, because the cholesterol in the eggs is very, very small. I think the biggest problem that you worry about cholesterol is what we call triglycerides that comes from the diet, because triglycerides do not get absorbed or does not dissolve in the blood or in the water because it's an oil. So the more oily food you consume, the more likely you're going to have high cholesterol. Egg does not have oil when you cook it most of the time, just a little bit spray of it. So I don't see any harm in having 1 or 2 eggs a day. And it's also a good source of protein and also a good source of calcium. And most of the people in the country, especially in winter, most of the population become deficient in vitamin D and calcium. So if you consume some eggs, especially during winter time, it'd be beneficial.
Well, that's excellent. I think I heard a collective sigh of relief from our viewers, knowing that that they don't need to stop having their Denver omelets. All right, well, we have some other questions coming in from our community, and some of these get a little specific, and I know it'd be hard to give you know, too much advice or guidance without knowing a specific patient and their other conditions and intricacies of their medical records. But let's see what we have here and see if we can offer some general guidance. So we have a viewer whose parent got an ablation after having a heart arrhythmia, and now there's fluid around the heart. Is that something that they should be concerned about, or what should they be talking about with their doctor with regard to that condition? Dr. Khan, you do a lot of ablations, as we learned in our introduction. So what guidance would you offer in this situation?
So yeah, sometimes it can happen when we do the procedure like ablation to have fluid around the heart. It depends whether it happened right away or it accumulated over the next few days. When it happens right away, then it's related to our procedure, like what we call complications, and that's a life-threatening condition. Luckily, we find it on the table or when we're doing the procedure and we take care of it. If it happens later, say 2 or 3 days later, it could be just as effect of the ablation, especially in A-fib ablation. Sometimes we burn the tissues, and the heart is a relatively small structure. The walls are very, very thin. So it does cause some inflammation. And that inflammation or irritation can lead to further fluid buildup around the heart. So usually it just requires some monitoring. I would say if we can monitor it like on a weekly basis to make sure it doesn't get larger, then we'll be fine. Most of the time the body absorbs it and we don't have to do anything for it.
All right, great, thank you. Both of you have a lot of experience around atrial fibrillation. So some of our viewers are wondering, what causes AFib? Is that something that we know? Dr. Khan, I just saw you make a face like I'm sure it's a much more complicated question. But Dr. Khan, do you want to start us out with your thoughts?
So yeah, it's very, very difficult to know what causes AFib. So usually when patient asks me in the office, why do I have AFib? And there's the common, and I say, I don't know why you have AFib. In fact, no one will know why you have AFib. But we do know that there are some risk factors that predispose you to have AFib. And common one is high blood pressure, hypertension. And second is usually having diabetes. The third is usually having sleep apnea. And the fourth one is having any other heart conditions. But at the end, I always say it's alcohol.
Thanks, Dr. Khan. And Dr. Carlson, is there anything that you'd like to add?
Well, I think there's some, I agree with Dr. Khan. There is certainly a genetic predisposition to it. So you'll run into families where everybody has AFib. You'll have a young male or female, they're relatively young, in their 40s and 50s, athletic, and they have atrial fibrillation. You'll get a family history from them, and their parents may have atrial fibrillation. And there's some other risk factors as well, to include sex, maybe males more than females, body size, so larger people more than smaller people, larger animals. Whales can go into fibrillation, whereas small animals do not. So, but those are some of those are non-modifiable. You can't pick different parents. You can choose whether to watch how much you eat or drink, and those are the modifiable risk factors.
Thank you. Dr. Carlson, you mentioned family history a little bit in there. So for people who maybe have a parent who had pretty serious cardiac disease or even died from a heart attack, when should that person start being seen by a cardiologist to understand and manage their risk?
Well, that's a great question, and I had that can actually start as early as childhood. To be honest with you, some people inherit very high cholesterol levels. If it's we're talking about coronary disease, or maybe they have some sort of their parents have some sort of an anomaly with their heart valve. So you may want to actually start in childhood to be evaluated, because you may need heart cholesterol medications when you're a child or an adolescent. Otherwise, as an adult cardiologist, I would say if you have a strong family history, you should probably start as early as 20 years of age to at least start to get screened for very high cholesterol or any other forms of heart disease. And then if you don't have if you don't have a very strong family history, you should talk to your primary care provider when you start getting into your 30s to have your cholesterol evaluated, your blood pressure evaluated. Those are the modifiable risk factors as you get older.
Thank you. And Dr. Khan, did you have anything that you'd like to add?
Yes, so the family is important, as Dr. Carlson was referring to. So there are now guidelines from Pediatric Society to check cholesterol early on, because the cholesterol deposit starts appearing on histology in the blood vessel when people are around 13, 14 years old. So we are learning more and more about those patients who have family history. So we screen them early and treat them early. And if you don't have any issues in symptoms in the young childhood time, then I think it's appropriate to start thinking about it when you are in the mid-30s, early 40s. And most of the coronary artery disease related, like the heart risk, goes higher when you get older. In men, I worry when they're 45 or older, and in female, they get some protection. So I wait till they're like in their 55 or 65-year-old, then you start worrying about cardiac disease. I don't know why females get this advantage, but it's there.
All right. Well, that's good to know. I think a lot of our viewers will appreciate that. So we've talked about cholesterol, but let's switch gears a little bit and talk about blood pressure and hypertension. Now, we have someone in our audience tonight who is asking about uncontrolled blood pressure. So what does that mean? And what should patients be looking for in terms of symptoms? Dr. Khan, would you like to start us out?
Yes, so the blood pressure is very common, unfortunately, very common in the country, and it's very difficult to control in some patients. Luckily, in majority of the patient, we can control it. But there are some, about 30-40% of the patient, where it's very difficult to control their blood pressure. And sometimes we use so many medications, sometimes 2 or 3 medications, but theoretically speaking, when we call it uncontrolled hypertension, when you are taking 3 or more medication and your blood pressure is still not controlled, we call it uncontrolled hypertension. It's very difficult to know why. Some people think it may be the lifestyle, like the patient may be eating too much salt, or they may be not exercising, or they may have underlying sleep apnea, or they may have just predisposition genetically to have uncontrolled hypertension. But if you're taking 1 or 2 medicine and blood pressure is a little bit high here and there, then that's not uncontrolled hypertension.
Great, thank you. Dr. Carlson, any other notes you'd like to share?
No, I think that's excellent. I think, or just to add, yeah, hypertension or high blood pressure is referred to as a silent killer, because many people do not know they have high blood pressure. It can lead to heart failure and kidney disease, and it can cause a lot of problems. Some people are symptomatic from it, though. You know, if their blood pressure is poorly controlled, they'll have headaches, and they can get short of breath. They can feel poorly, but it's one of the most important modifiable risk factors we have for heart disease. So, and there are great medications these days to control blood pressure, as well as many lifestyle interventions, which we can guide patients and people through to assist them.
Thank you. And we've talked a little bit about an extreme case, but for somebody who's maybe borderline, um, speaking to some of the lifestyle changes that you mentioned, Dr. Carlson, are there things that someone can do to bring down their blood pressure without the need for medication if they're just on that cusp of being borderline?
Yeah, certainly. Oftentimes we talk about what to exclude from your diet, whether it's salt or, eggs potentially, but there's things that you can include in your diet which are beneficial. So the DASH diet, so uh, adding potassium and calcium into your diet. Where do you get those from? Fruits and vegetables, low-fat dairy products. That's part of the DASH diet. That's beneficial. That can help lower your blood pressure. And exercise is key. Weight loss is key. You lose 5 or 10 pounds, you'd be surprised how much your blood pressure can actually come down. The challenge is that can be difficult to do. So modifying your diet, adopting a healthy lifestyle, avoiding alcohol, and treating sleep apnea or sleep disturbances in general can all be beneficial.
So I did
Thank
like
you.
that comment you made at the end about alcohol. I think I've noticed that people who drink alcohol, that's why their blood pressure all of a sudden goes high. Like blood pressure is usually well controlled, and all of a sudden it goes high. And when you ask them a few times, then finally they say, yeah, they've been consuming more alcohol than usual. So that's one of the important lifestyle modification they can do to bring their blood pressure down.
Yeah, very true. That's good information. Thank you. And along the lifestyle changes, we know that smoking is bad for you all around, bad for your lungs, bad for your heart. But what about vaping? Is that something that you would discourage your patients from doing for their heart health? Dr. Khan, you can start us out.
Okay. So yeah, so vaping, as you know, is the main reason people vape is because it has nicotine in it. So number one, vaping is relatively new, so we don't have enough data or long-term data to say that it's going to be harmful or not. But if we assume that nicotine is harmful, causes more heart attacks and more heart disease, then vaping will do the same because the nicotine content is pretty much the same. As far as the smoking itself, like in terms of the lungs condition goes, we don't have any data in the elderly patient, but in young individuals, especially teenager, there are a few reports that it causes some pneumonitis, like a pneumonia in the lungs because of the vaping. So either way, it's a bad thing to have. And my suspicion is down the line, we'll have more data and then we can say don't use it at all. What do you think, Dr. Carlson?
I agree. It's just another addictive uh, problem to take up. So I'm not going to advocate it. I think there's some data to suggest that it helps with stopping cigarette consumption, but you're just substituting probably one problem for another problem. So I would just try to stay clear of it.
Very good. Thank you. Going back to our live chat, we have some folks who have A-fib and are considering having an ablation done to help resolve that condition. So, Dr. Khan, our viewers are wondering if the procedure is dangerous and if they should be concerned, especially if they are older. So, what words of wisdom or encouragement might you give a patient who's considering an ablation?
So it's a good question. Ablation, although is an invasive procedure, but over the last 20 years, we have come a long way, especially with the evolution of the technology. So because of the new technique, new technology, ablation is much more safer. In fact, it's safer than crossing the road. So if you are concerned about having an ablation done and you are hesitant because of complications or risk of the procedure, I would talk to your physicians. It's relatively very, very small risk. Most of the time, we send the patient home the same day because it's becoming such a simple procedure for us. In the old days, it was a very difficult procedure, but now we can do it pretty quickly and safely.
Thank you. Dr. Carlson, anything you'd like to add?
No, I second Dr. Khan's statements. It's quite remarkable some of the advances of technology we've seen over the past 20 or 30 years with cardiology procedures. In the 1980s, 1990s, if you wanted a therapy, an invasive therapy for the treatment of atrial fibrillation, you would have to undergo an open heart Cox-Maze procedure, which was pretty dramatic. And it's quite remarkable that we can do a procedure in 2 to 3 hours, and 2 or 3 hours later, patients are going home. And the efficacy, the benefit for reduction in atrial fibrillation is upwards of 80% compared to medications at 50%. So it's a quite remarkable time to have some of these treatments available. And of course, lifestyle change is beneficial as well. But for those who need another option, I think we have great advances in 2023.
Thank you. We have a question from a viewer about any cardiac benefits or maybe if there's harm to your heart in using some of these GLP-1 medications that we're seeing a lot in the news, like the medications like Wegovy, for example, that are mainly used to help people maintain blood sugar. Have you heard anything about whether these medications are safe for your heart, or if there should be a concern for people taking those medications? Dr. Khan, please start us out.
Yeah, so it's a good question. These are newer medications, relatively newer. They've been around for several years now, and we have some data on them. And there was a recent publication, especially with semaglutide, which shows that people who does use it, they lose a lot of weight, almost 40 pounds sometimes. So I'm not sure whether that leads to, but overall, it makes them live longer, like cardiovascular mortality decreases and the morbidity also decreases. So people who take these medicine have less heart attacks. So it's definitely safer for people who have concern about their heart while taking these medicine. It's not clear why they get the benefit. I think it may be the weight reduction, but there may be some other mechanism that I don't understand.
All right, that's fair. Dr. Carlson, anything to add?
No, I think the initial data on these medications are good. They're in demand. They're in demand by a number of patients and people who want to lose weight, who have diabetes. Weight loss is good. The difficulty with weight loss for many people is it's difficult to achieve. So, and we've had difficulty acquiring good medications, and so these may be groundbreaking medications. But some of the critiques I've heard or have been discussed is, whether, if you're relatively young, is this something you want to do for 20 or 30 years, or whether you might need to change your lifestyle independent of medications. Do you want a medication that's going to cause some degree of nausea for weeks or months on end just to get that weight loss? But I think the data is good. Initially, it's going to lead to beneficial cardiovascular outcomes, but at what cost to the person and at what cost to society? Those are the long-term questions.
Yeah, I think that's a very good point Dr. Carlson brought up, because for younger people, if they keep it taking for 5-10 years, we don't have that data. We do know that the weight loss is only good for the first 3 to 6 months. It doesn't sustain after a year or so. So if you're thinking on those lines, then probably short-term courses are better than long-term till we have some more data.
Thank you. This is a great conversation. Let's keep it going. We do have a question in our audience about POTS. So our viewer had POTS emerge while she was pregnant, and seemed like the symptoms abated but have returned. Is that something that you're familiar with? Is that something that might be permanent for our viewer? Again, knowing that this is very specific to each person. So we're just talking about generalities here. But Dr. Khan, what are your initial thoughts?
So POTS is unfortunately very common, especially in female, and it can happen during pregnancy. In fact, I see it most often in the first trimester to second trimester, the symptoms especially. It gets better towards the third trimester and postpartum. And then it can occur again. We don't know when and why, but it can occur if someone gets sick again. So even if you get a flu or some other disease, it can come back and then make it feel bad for a few weeks, sometimes few months. In other instances, it's a one-time thing and it goes away and doesn't bother you till next pregnancy. And sometimes it may not happen in the second pregnancy. The actual reason why people have it, no one really understands, but it's causes the dizziness, the symptoms, and it's very difficult to treat. There is no specific therapy for it.
Thank you, Dr. Khan. Dr. Carlson, anything that you'd like to add?
I guess I'll add a little bit. Yeah, so POTS is very common. Oftentimes it's underdiagnosed. You could have a young individual who has some exercise intolerance, who gets shorter breath, who gets winded, may have some abdominal pain, chronic headaches. So oftentimes there's this disorder, chronic fatigue syndrome. So somebody might have chronic fatigue syndrome. They feel miserable all the time. And then you do a set of vitals on them. And when they go from lying on their back to standing upright, their heart rate just shoots up. And that's abnormal, but it may be difficult to recognize earlier. Maybe their heart rate's elevated all the time. That's called inappropriate sinus tachycardia. And POTS and inappropriate sinus tachycardia are two kind of functional cardiac disorders, which can be debilitating in younger individuals, but maybe under-recognized. And the treatments can be difficult, but at least you can validate someone's symptoms and let them know that they're not crazy, that they have an issue which can be managed or supported or at least acknowledged.
Thank you.
These are very good points. Very good points.
Now we have another question from our viewers about another specific condition, and I'm probably not going to say this correctly. Dysautonomia. Are either of you familiar with that condition? Do you see that in your practice? Dr. Carlson, I saw you maybe acknowledge that you've heard of that before. Yeah,
I think POTS or postural orthostatic tachycardia and inappropriate sinus tachycardia may fall under the umbrella of a dysautonomia. Your autonomic nervous system is responsible for regulating your heart rate and your blood pressure, and so this is where it gets a little bit more complicated and takes almost like a team approach. If we may need to, if someone has a dysautonomia, they have POTS, they have inappropriate sinus tachycardia, we would of course love to be involved in their care, but we may need to ask for assistance from a neurologist to get their input. Maybe a patient has some sort of neuropathy or a problem with their nervous system. I don't know, Dr. Khan, I don't know what your typical approach is, but I like seeing these patients, but I'm also quick to ask for assistance from other specialists.
Yeah, so I agree with you. Sometimes I have the same approach. If they have dysautonomia, I'd rather get some help from other specialties, especially neurologists. Most of the time, if this dysautonomia has some other condition related with them, especially diabetes or hypertension or some other neuropathy, then you can come up with a better plan. But if it happens, as you mentioned, because of the POTS, which is also part of dysautonomia, or vasovagal syncope, or these inappropriate sinus tachycardia, then the approach is the same. And we try to make patient feel better whatever we can. But the good thing is these are not life-threatening conditions, just disabling sometime, but most of the time people recover and they don't have any long-term consequences from it.
Thank you. Now we are coming up to the top of our time, but I think we've got just enough time for a couple more questions. One that I've seen a couple times come through the chat here is for folks who have had A-fib and have had an ablation, and the issue reoccurs, is it safe to have a second or even a third ablation to correct the A-fib? Dr. Khan, I'll ask you to start us out.
Yeah, it's a good question. So yeah, so as I mentioned in the beginning of the conversation, we cannot cure A-fib, but we can control it like every other disease, like diabetes, hypertension. So having second or third ablation is not going to harm the heart. In fact, the more ablations we do, second or third, the results gets better. As Dr. Carlson mentioned, we can be successful up to 80% of the time, keeping people in normal rhythm when we do ablation. So having a second or a third ablation is not really unheard of. In fact, some of the study shows 1/3 of the patient requires more than one ablation to get optimum results.
Wow. Okay. Dr. Carlson, anything you'd like to add there?
No, and for those patients who are very difficult to control, who may be having bad heart failure symptoms, especially if they're getting a little bit older, oftentimes we don't like discussing, but it's just, I'll throw out, sometimes you may benefit from a pacemaker, and then we can burn the connection between the top and bottom chambers. And for some patients, that's almost like a cure. Their top chambers will remain fibrillating, but then we can control their bottom chambers, and that can really help them out. So it's a journey more than there's it's not more of a journey sometimes with atrial fibrillation rather than a destination. And so I feel like I'm here to accompany patients on their journey with atrial fibrillation. No one's the same, and everyone has their own special needs.
Of course, each person is different, right?
Of course.
All right, one more question from our live audience here. There are folks who are wondering about COVID and the relationship with cardiac problems. Is that something that you have seen in your practice, where patients who have had COVID also have heart problems? I feel like I've read articles about that, but would love to hear your thoughts on it. Dr. Carlson, would you like to start us out?
COVID and the heart, I think, like, I'd back it out a little bit. Many viruses can affect the heart. You can get mild cardiomyopathies. You can get severe cardiomyopathies from many different viruses, to include COVID. And so, personally, I'm not sure if the coronavirus is any more special than some of the other viruses that we've dealt with. I think majority of people have not had significant insults from the coronavirus in their heart, but like atrial fibrillation, everyone's different. So I can't make any general recommendations. I don't know if Dr. Khan feels differently or has had different experiences with the coronavirus.
As far as the COVID-19 and coronavirus infection goes, and for the heart, so I don't really think that it affects the heart as much as it was advertised in the media. There was concern about, especially with the vaccine, that it can lead to pericarditis or myocarditis. I think those are overblown. I think the virus itself can cause mild myocarditis or pericarditis, but the incidence is less than 1 in a million. So I wouldn't much worry about that part. I have seen some, what we call nowadays, we call them like a chronic COVID conditions, where patient comes in with tachycardia, like a sinus tachycardia, and they're getting short-winded. Most of the time, they present to me about 6 to 9 months later. So, and if the symptoms persist up to 6 months to 9 months, then we call it chronic COVID. The good thing about those patients is that, one, it's easy to treat. We give them some beta blocker or some other medication to make them feel better. And pretty much majority of them from the heart condition, they get better. Their tachycardia resolves. They may have some other lingering shortness of breath or lung problem, but that's usually not related to the heart.
Great, thank you. Well, this has been a great conversation. I feel like this time has just flown by. We are at the end of our time tonight. And so just in closing, I'd like for each of you to leave our viewers with just one thing that they can do to take care of their heart today. Dr. Carlson, let's start with you.
I would recommend you move and exercise. I think it's probably one of the best things you can do in today's society. Remain active.
Thanks, Dr. Carlson. And Dr. Khan, your thoughts?
Don't smoke. Never ever smoke or vape. You will live longer. And keep your weight or BMI less than 25. You will live at least 40 years. That's what the data shows.
All right, well, thank you so much. Everybody, you heard it here first. Move and don't smoke. That's how you can take care of your heart today. Well, thank you so much, Dr. Carlson and Dr. Khan, for joining us tonight and sharing your expertise. And a huge thank you goes to our viewers out in Facebook land for tuning in to this Ask the Expert event this evening. If you would like to learn more about Mary Washington Healthcare and our cardiac services, you can always visit us online at heart.mwhc.com. Until next time, be well and stay safe out there.
Thank you, everyone.
Thank you.